Welcome to our channel. Today, we're discussing a critical topic in the use of dual antiplatelet therapy in patients with unstable angina and non-ST elevation myocardial infarction. Specifically, we'll explore the findings of the CURE trial, which examined the combination of clopidogrel and aspirin. Let's dive into the key takeaways and understand how this therapy impacts patient outcomes. Aspirin, a cornerstone of antiplatelet therapy, works by irreversibly inhibiting cyclooxygenase, thus preventing platelet aggregation. Early trials like the VA Cooperative Study in 1983 and ISIS-2 in 1988 demonstrated aspirin's effectiveness in reducing mortality in patients with unstable angina and non-ST elevation myocardial infarction. Clopidogrel, a newer antiplatelet agent, targets P2Y12 ADP receptors on platelets, offering a different mechanism of action. The CURE trial aimed to determine if adding clopidogrel to aspirin would improve outcomes in acute coronary syndrome. The CURE trial enrolled 12,562 patients with unstable angina and non-ST elevation myocardial infarction. These patients were randomized to receive either clopidogrel with a 300 mg loading dose followed by 75 mg daily plus aspirin or a placebo plus aspirin. The primary endpoint was a composite of cardiovascular mortality, non-fatal myocardial infarction, or stroke. This large-scale study provided critical insights into the benefits and risks of dual antiplatelet therapy. The combination of clopidogrel and aspirin reduced the incidence of the composite endpoint, which included cardiovascular mortality, non-fatal myocardial infarction, or stroke, from 11.4% to 9.3%. This represents a relative risk reduction of 20%, with a 95% confidence interval of 0.72 to 0.90 and a p-value of less than 0.001. The reduction was primarily due to fewer myocardial infarctions. Secondary outcomes showed reductions in cardiovascular mortality or non-fatal myocardial infarction, but there was no significant difference in stroke rates. However, the use of dual therapy was associated with an increased risk of major bleeding, rising from 2.7% to 3.7%, with a relative risk of 1.38 and a p-value of 0.001. Additionally, any bleeding events increased from 5.0% to 8.5%, with a relative risk of 1.69 and a p-value of less than 0.001. The American College of Cardiology Foundation and the American Heart Association guidelines recommend dual antiplatelet therapy with aspirin and either clopidogrel or ticagrelor for patients with non-ST elevation acute coronary syndrome. The choice of agent and duration of therapy should be based on individual patient risk factors and clinical presentation. These guidelines have been shaped significantly by the findings of the CURE trial, emphasizing the balance between reducing cardiovascular events and managing bleeding risks. The CURE trial established the benefit of adding clopidogrel to aspirin in patients with unstable angina and non-ST elevation myocardial infarction, significantly improving cardiovascular outcomes while highlighting the increased risk of bleeding. This trial has been foundational in shaping current guidelines for managing acute coronary syndrome. As always, treatment decisions should be tailored to each patient's specific circumstances. Thank you for watching. If you found this information helpful, please like, subscribe, and hit the notification bell for more updates on the latest in cardiology and healthcare. Stay informed and take care.